Second-line treatment for patients with Waldenström's, to some extent, depends upon a number of different issues. First is, what treatment did they get first line? How well did that treatment work? What sort of other comorbidities does the patient have? What sort of expectations does the patient have? Does the patient want to be on a treatment that would be given continuously, that may be associated with ongoing toxicities, such as a BTK inhibitor? But I think if a patient has a very long response to their first-line treatment, and if that's what we use mostly, which is like chemoimmunotherapy, bendamustine and Rituxan, it's conceivable that another chemoimmunotherapy might be given as a second-line treatment. We're reluctant to use too much bendamustine, as it has long-term toxicities and effects on the bone marrow. I'm not sure most of us would want to recommend a second-line bendamustine rituximab, but there are other chemoimmunotherapies that could be used for patients who have, let's say, 5, 6, 7, 8, 9-year responses to their first-line therapy. But the other major therapy that's used are BTK inhibitors. We know the BTK inhibitors are active in Waldenström's. We know that there are next-generation BTKi inhibitors, such as zanubrutinib and acalabrutinib, that have less toxicities than, let's say, the first-generation ibrutinib. So that means less worry about hypertension, about atrial fibrillation, about bleeding problems. I think if a patient were to have a shorter response to their first-line therapy, such as chemoimmunotherapy, in the range of 3-4 years, we would want to go to a next generation BTKi inhibitor, such as zanubrutinib or acalabrutinib, where these are available and approved and funded by various insurance agencies. Or government funding agencies. There are other options, and there are other options that can be used third line, fourth line, but right now I'd say BTKi inhibitors are our next choice.